Welcome to Community Conversations. I'm your host, Steve Mantis, and my guest today is Susan Pilatzke. She's the Vice President of Health System Strategy at the Northwest LIHN, the Local Health Integration Network. Welcome, Susan.
Thank you, Steve. Nice to be here.
So, Susan, let's start a little bit about your background. Are you a local girl here in Thunder Bay?
Well, I'm actually from Fort Frances originally,
Oh.
but I moved to Thunder Bay and never left. So I'm a nurse by profession and have been in the healthcare system for quite some time in a variety of roles. My sons live here in Thunder Bay and I have 2 granddaughters.
Well, congratulations.
Thank you.
Well, that's totally great. So, how long have you been working at the LIHN?
10 years, just
10
over
years.
10 years now.
And is
at
that
the
how
LIHN.
long it's been there? How long has the LIHN been around?
2005 we were established
Okay,
in the
so 12,
province.
13 years. And so tell me, what is the LIHN? And give us some history around why was it brought in 2005?
So in 2005, the province set up the LIHN system, 14 across the province. And the role of the LIHN is really to focus on integration, planning, and engagement. And we now have subsequently in the past year taken on the role of home and community care. At the time that we were set up, it was really to have more local voice from the people that live in the region. Typically we have people in Toronto and ministry making decisions around what's best for priorities in health. And this allowed more local voice and input.
And so what's the geographic area we're dealing with here?
It's just a little vast. It's 458,000 kilometers.
Is that all?
That's all.
458,000, come on.
Hudson's Bay, right through to the Winnipeg, like the Manitoba border, down to the south of the U.S. border, and just before White River. That's our extent of our geography.
So almost all of northwestern Ontario.
Well, a good portion of it.
I mean, we're not really sure where we draw the line, whether the Sioux is in the northwest or not. It's always
The
been
Sioux is in the northeast LIHN.
In the
So
northeast.
White River beyond goes to the Sioux and up to James Bay. So they have a fairly large territory.
Okay,
as
so
well.
there's no Kenora LIHN. It's
No.
all
One LIHN,
it's all in
northwestern Ontario.
And we're headquarters here in Thunder Bay.
Located in Thunder Bay, and probably really important is the population. We have 231,000 people in that large geography.
So do you service right up into the northern communities, the remote communities as well? Is that all part of?
Absolutely. So the LIHN itself is, and our board would say, our mandate really is that all of the residents of Northwestern Ontario are people that we care for and really are looking at improving access to services. So when you look above Sioux Lookout into the fly-in northern communities, all of those residents are also part of this LIHN region.
And how does that work? I mean, this is a provincial organization, LIHN. It's just Ontario.
Yes.
But the northern communities are mostly relate to the federal government. How does that integration work?
Well, we have a wonderful relationship with Health Canada and with our First Nation communities. We work closely with all of the partners because that jurisdictional issue exists. And respecting that and respecting what is happening with the planning or the federal plans versus the provincial plans and then the local communities plans, we work closely with the partners to understand still what are the health needs, what are the priorities of people living in these communities, and our role is really to improve access to care. So that's our focus.
So in terms of what comes under the LIHN, so we're talking about health. There's a whole lot of pieces of health. What's included into that umbrella?
It's a very good question. Not everything on health is underneath the LIHN, but we have the long-term care homes across our region, all the hospitals in our region, the community health centers, there's 2, one in Thunder Bay and one in Ignace. And then we have the mental health and addictions agencies, community support services like the Alzheimer's Society and Westway and Red Cross and Haggie. And then we also have home and community care, which we recently took on last June. 17, I should say, we took on home and community care, which was the former CCAC services for our region. And we have a relationship with public health and primary care now. Things like ambulance services and laboratory services and that remain under the province.
So it's like you're an arm of the provincial government that is administering funds to these, or do you do direct service? Where do you draw the line in terms of what the LIHN actually does?
So the LIHN plans and funds and integrates and then also engages with community, and the delivery part that we do now is directly home and community care services. So
this is the new piece.
This is the new piece in the last year. So now if you needed home care services, you were discharged from hospital, our home and community care division would set up the services with providers in our communities. With respect to all of the others, we have accountability agreements, and we fund the hospitals, we fund long-term care, we fund the community health centers, Aboriginal access centers, a number of providers, 89 in total, across our region as a whole, we have agreements with. And we are a Crown agency of the government, so we're an arm, you're right, of the government with responsibilities to follow provincial directions, provincial priorities, however, from a local voice and perspective.
So we have OHIP, the Ontario Health Insurance Program. That funds a certain amount of health care as well. How does that integrate with the LIHN?
So it really is, that's a government-funded program. How we interrelate with it is understanding where there might be gaps in, and I'll give examples, you know, babies that may be born in northern communities might not be registered with OHIP. So we do have relationships on talking about how do we ensure that people have access to the provincial health system and actually can work through mechanisms to connect into the OHIP funded programs. It doesn't mean they don't access services, but that's a provincial program and service that's offered, not the LIHN.
So does some of the LIHN funding come through OHIP?
No. Our funding comes directly from the government, and it comes based on, there's historical funding for hospitals. We have $675 million that we manage in this region as a whole.
That's your whole budget for the
Our
LIHN?
whole budget for the LIHN. So that
$675 million.
for the geography, yes,
Okay.
and for the population. And it flows from the government to us, and then we flow that through to the hospitals or to whatever the service providers are that they have within their agreements. And to some degree, it's discretionary, so that we can say, you know, Community A's identified this as a real need and a health need. We see that, we understand that, and then we fund that initiative with an agency that has an agreement with us.
So we've been hearing at the hospital that, geez, you know, this winter it was like totally overfull. There are people sleeping in hallways. Does the hospital come to you at the LIHN now and say, what do? We need more money? Or do they go somewhere else?
They go directly to us.
Okay.
So the voice, we're the local voice, if it makes any sense, for the region as a whole. And we encourage our providers come to us when there are those issues. So in the case of the hospital we're always monitoring the system, we're understanding system pressures. And Thunder Bay Regional, for example, came and said, like, we're in a crisis here. We really need some bed capacity. So together with system partners, we look at then what's happening, what's sitting in the emerge, are there any beds really to admit people, and what are the safety and quality issues, and then have worked with them on a solution for an interim placement of patients over at the Hogarth Riverview Manor site. So that's how we work together.
All right, we need to take a short break.
Okay.
Please stay with us, and we're going to be right back. Welcome back to Community Conversations. I'm your host, Steve Mantis, and my guest today is Susan Pilatzke, who is the Vice President of Systems Planning with the Northwest LIHN, that's the Local Health Integration Network. So, Susan, in the last episode we were really talking about the hospital. And because it's in the news all the time, people have heard this information. So you described how, okay, they're in crisis, they identify that, you work with them to identify what exactly is going on and what are the options. What is your ability? Like, you've got this budget, it sounds like a big amount of money, $675 million. but you have to do a lot of things with that money. So we hear, yes, we need more long-term care beds, but they're not in place yet. How do we make those decisions to kind of go, well, do we sock away money for the long term to solve an issue that may be reoccurring, or do we put the money into what we need right now? Like, and I'm sure there's way more options than that.
Mm-hmm. It's a bit of both, okay? I think really when you look at it, perhaps maybe to tie that together is if the regional identifying its pressures to us and with other stakeholders, so community partners and our home and community care division, we then assess that, as you say, we look at options, and then we also relay that to our partners at the ministry level and say, we're in a situation here where we need to open some more capacity. We have a space that we can open the capacity at, and this is what we need the approvals in the system to do. And with respect to that, given the credibility and the knowledge and the information that exists there from our local view, the ministry agreed and we opened up those spaces.
Now, when the ministry agrees, does that mean they're giving you more money?
Not always do we need more money. So sometimes we might still have some discretionary money. And in other cases, we do need to really say this is the cost of doing that and this is the ask that we have of you at the ministry level. And again, that's all with evidence and information that we put forward. And then the ministry has been really receptive to listening to that and responding to that accordingly. And I think the other piece that goes into play with all of the funding decisions is we have a decision-making priority setting framework that has been adopted by all the LIHNs, that's board approved, and it really helps us look at the criteria to say how do we address equity, cost, quality, a number of features as we make decisions with maybe some of the discretionary money we have. To your point earlier, we have $675 million. It sounds like a lot, but a lot of that's already fixed in organizational costs. Mm-hmm. So we are looking at those other funds that are a bit more fluid that we can do some things with, or asking for more.
And kind of coming back in a way to the interaction with, in a way, the federal government and the provincial government mm-hmm. around Indigenous populations. Mm-hmm. So we've got the community health center in Thunder Bay and one in Ignis. Mm-hmm. Well, there's Mishkiki that's kind of like a community health center, primarily for Indigenous folk. Do they access funds through the LIHN, or is that through the federal government? And how are those integrated together? Because we're all here in Thunder Bay.
So I think those are all the complexities of this system.
I'm glad I'm not one
You're
making
not
the decisions.
The only, no.
I'm telling you, I'd kind of go, what do I do?
Yes, I think first and foremost it's about the people, right? What do the people need? Where do we need to put the funding to help people? And so I think in the case of Anishinaabe Mishkiki, we have two other Aboriginal access centers, one in Fort Frances and one in Kenora. And we work with them in certain programs that we do fund, while at the same time they may receive funding through other arms of ministry or federal government. So the system is funded by a variety of sources. And again, it's our partnership with the stakeholders that we really look at. What's the need, what's the priority, and then who provides that funding should be transparent to the people. At the end of the day, it's about meeting the patient's needs.
So in the 89 organizations that you fund, is that like their core funding, that then they have special programs, they may go elsewhere for additional dollars, for additional services? Yeah,
depending on the service provider, there are different sources of funding. So it might be children and youth services, it might be community support services, it might be federal government sources. So there can be a variety of funding sources that help support health care delivery.
So let's say here our Thunder Bay Community Health Center there on Simpson Street. Mm-hmm. I'm not sure I've got the name right. So you give them X amount of dollars. They're hoping to get, because they got demand, they're hoping to get dollars from elsewhere, but they don't get them. The demand's still there. How do you deal with that?
So when we're the primary funder, so the Norwest Community Health Center, when we're the primary funder, again, if they have a need they've identified and they say, this is what we're seeing. We see a population of people, maybe there are vulnerable population that really needs some services in mental health and addictions or whatever that be. They submit a business case to us and they ask us and request from us, here's what we'd like to do, here's how we'd like to expand our services, this is the cost we're projecting. And then again, we assess that and we determine if we have available funding and it's the greatest priority and need, then we allocate that money accordingly. And it's a decision-making process that goes through to our board as well to help say at the end of the day, these are the needs we're meeting, this is how it fits and aligns to the work that we're doing, and this is the organization that we're recommending receives it.
So how many staff work for the LIHN?
Well, we're bigger now. So June 21st, we gained probably about 200 additional people with the Home and Community Care Division.
And so some of those are the direct service providers.
They are
Personal support
they're
workers.
RNs and RPNs and nurse practitioners and team assistants, a variety of roles there. But we also had a core group of about 45 LIHN staff.
Okay.
We're about, I'm going to say 290 in total size now as a result of the integration.
And so how does the community plug into those priorities, setting the priorities for health care, health provision in our region?
I'm going to just step back a minute to the question you had before, because I also wanted to share there's 15 different sites across our region that have community care coordinators in that are actually looking at and doing home and community care as part of our work. So in communities, Fort Francis, Kenora, Rainy River, you name it, we have staff out and about in all of the regional sites to help support the care delivery.
Right.
Now to the point, the next question is how does the region get involved in planning? We have just launched a campaign of Picture Your Health. And one of the things we do is that we're obligated by our agreement with the ministry to produce a strategic plan every 3 years. It's called an Integrated Health Services Plan, and we're on the 5th version of that now. So we are
Every
now,
3 years?
every 3 years there's a cycle. Okay. So we're now looking at 2019 to 2022. And we're out about in a campaign right now across our region as a whole with over about 25 events and some community fairs and meeting with people in the community and asking them, if you could picture your health, what would that desired future state look like? And help inform that. So that's one of the ways that we do it is engagement with people across the region and having them tell us the stories of challenges or gaps in services or even ideas of making a difference.
Please stay with us. We have to take a short break, but we're going to find out a little bit more about how you can get involved in setting the priorities for our healthcare here in Northwestern Ontario. So we'll be right back. Welcome back to Community Conversations. I'm your host, Steve Mantis, and my guest today is Susan Pilatzke, the Vice President of Systems Planning with the Northwestern Ontario LIHN, the Local Health Integration Network. So Susan, we were just talking about the Picture Your Health campaign that you're using to engage folks in terms of planning the next 3-year cycle. So you'd mentioned that you're out and about. So what are some of the concrete ways that people can find out where you're going to be and how to participate? What's the easiest way to start with that?
Well, the easiest way is going to www.picturemyhealth or yourhealth.com.
Okay, right there on the web.
Well, we'll show that, picture.
We'll put that on the screen.
To go there. So what it tells you is the events that are happening, the dates and times they're happening, but we've also been doing advertising in the newspaper and through media, through interviews on radio. There is a Twitter, there's also other mechanisms to actually participate. And for people that can't come to these events, you can do the survey online.
I'm feeling so out of it. I haven't heard about this until now. Like I'm kind of going, geez, I thought I was plugged in. I guess
How do we get the blast out there? I think this is a really great opportunity because we really do want to hear from people. I think one of the things that really is important, and we don't just use this campaign to be the only thing that helps inform our next 3-year plan. we've been talking to people over the last several years, and each year we have a number of people we engage with who tell us these are the things that aren't working well. They're not connected. They're not creating a better patient experience. And they're saying, if you could do this, that would fix this. And so we use all of that to inform our plan and priorities.
And how do you integrate kind of health promotion, wellness, rather than picking up the healthcare on the other side? How do we do preventative piece? How does the LIHN support that?
Well, it's a very good question, and I know one our board has grappled with in terms of we're really looking at population health. You need to be thinking about health promotion. To a large degree, when LIHNs were set up, we were focused on the illness, the management of disease, and the funding of disease treatments and management. So now our opportunity, since the new mandate letter came in 2017-18, is our relationship with public health and the focus on promotion, health promotion activities, primary prevention. How do we start to address obesity? How do we change dietary habits? How do we actually, together in partnership, actually make those advances? So it's a very different opportunity. And in our particular plan development, we work with the public health to jointly put in key objectives that will do that together.
So my background, a lot of it is occupational and occupational health and safety, and what happens when that isn't successful. And when we look at population health, some of the big factors are income, poverty, early childhood development, and actually your relationship at work, where you spend most of your time. So I know at St. Mike's Hospital in Toronto, some of the docs are prescribing income. They've connected with the legal clinic that will help their patients get onto benefits that will help them get the food that they need so that they can be healthy. Are there concrete examples of things that are happening here in the Northwest that might be new and innovative, that might see a return down the road?
So I think one of the biggest things is you're talking about social determinants of health, right? Housing, education, poverty, more income. What we're doing right now that might be the greatest concrete example is working with our social services system partners, our public health partners, our community partners, police, ambulance, you name it, to start to look at those determinants and really building again, strategies together that we can do to help support people that don't have that access to services or those incomes. And in the cases of our partners, even within our communities, what are the communities themselves saying that are the greatest needs? And that's how we're starting to approach that work. We don't have direct maybe funding going to that at this point in time, but we will collectively and jointly do that work.
So, I'm kind of going, okay, I've been working in the community for many years, and when I'm working at the March of Dimes back 30 years ago, we're concerned about the folks we provide service to, but we're concerned about our organization as well. And we kind of go, geez, if we don't have money here, we're not going to be able to provide the service. So some of our energy is going into making sure that we get our fair share. That dynamic can sometimes not recognize enough the needs of the population that we're trying to serve. Not bad intention or anything, it's just the way organizations are. We have to, like our family, we want to keep all our family together, and so we're going to sometimes take actions that may not help the neighbors. You're dealing with integration. That's one of the dynamics that exist in our community. How do you recognize and balance some of those challenges?
We have had lots of conversation with our providers of that very, very important concept. Because you can say the word integration and people think it's amalgamation and mergers and be very afraid of that. But we also talk about integration from coordination of care, improving the patient experience, and focusing on the patient. That is our goal, is that it's a patient-centered model. It's not a provider-centered model. And that's a shift in thinking. And you'll see some of the writing in Patients First about breaking down the silos. We've talked to our providers about how do we take a system approach now? How do we really look at the population and say, these are the greatest needs here? If it were to address food, if it were to address safety and security, if it were to address housing, how are we working with those partners to do that? And a great example that we have is we've worked with the Kenora District Social Services Board and partnered with them to actually get a 20 unit housing built in Sioux Lookout to help support those needs, because that's a component of social determinants of health. So that's how we're trying to address that.
Susan, we're out of time. I have like a whole bunch more questions. Oh my gosh, I want to be part of, Picture Your Health, because it's a big part of my life nowadays. I'm thinking more and more as I get older. So we'd like to talk more, but now it's your chance as audience. Any ideas or thoughts you have, definitely go to that website that we mentioned, the Picture Your Health. Also, you can find us on Facebook, Community Conversations. Share your thoughts and ideas, and stay safe and healthy until we see you again.